Hello and welcome to Kingsbridge HealthStyle, the health and wellbeing podcast from the Kingsbridge Healthcare Group. My name is Avril Keys, your host, and I will be putting real patient questions to our consultant specialists from across the group. From diagnostics through to treatment, we will give you the lowdown on what to look out for and when and how you should make an appointment. Thank you to everyone who has sent through their questions. If you do have a question or would like to find out more about any of our services, contact details will be listed within the information box below. So let's get started, and I hope you enjoy listening. So joining us today, I've got Dr. Turlough Farnan. And Turlough, you're an ENT doctor. Could you explain to me what you get up to every day in your job?
Avril, I think that the large part of my day would be split between outpatient activity and theatre lists. So in a typical morning, I might do an outpatient clinic where I would see maybe 12 to 14 patients, and that would be patients referred from their GPs, or sometimes would come from directly from their insurers. And some patients would be self-referred. So for example, they might be looking for an operation to change the shape of their nose, and they want to come and talk to me about that. So I'm going to see the full range of ENT conditions. We'll see patients with ear problems, hearing loss, tinnitus, dizziness, pain in the ear, discharging ear, that sort of thing. For me, I have a subspecialist interest in conditions of the nose and the sinuses. So I would see a lot of patients with nasal blockage and sinusitis and nasal polyps and allergic rhinitis and things like that, you know.
Okay.
And then we also see patients with throat symptoms. That can be hoarseness, sore throat, recurrent tonsillitis, that sort of thing. So a full range of ENT symptoms. A lot of them are very common symptoms. So that would be a typical morning. We'd be seeing 12 or 14 patients and just having a consultation, asking them about their symptoms, the duration and how severe they are, and doing a full examination of the appropriate body part to see what's going on. And from there we can decide on the next stage of treatment, which might be investigations or medical treatment, or possibly added to a waiting list for surgery.
And then do you go on and do the surgery as well?
Yeah, so if somebody needs an operation, I put them on a waiting list, and we'll operate either here in the Kingsbridge, Belfast, or we also have theatre lists now available up in the northwest.
Ballykelly?
Up in Ballykelly, yeah. So we, for me, I would do, again, a lot of nasal procedures. So for blocked noses, I'll be doing septoplasties to straighten the nasal septum to help people breathe better. If somebody has a broken nose, they might need the nasal bone straightened, so I'll be doing that. I do a lot of endoscopic sinus surgery, so that's going in through the nose with an endoscope, and we can see the inside of the nose and the sinuses on the screen in front of me.
Okay.
And from there we can do what needs done to help the sinuses function better. So we do a lot of sinus surgery.
Okay.
We also do a lot of routine ENT surgery, which would be things like tonsillectomy and adenoidectomy in children, and putting grommets in the ears to help children hear better. So a full range of ENT surgery, and we have a couple of other consultants in ENT, but with subspecialist interests in the ear or in the throat, for example, and we would often refer things between each other if it fits into their particular subspecialty.
Yes, so that's always quite good. You've got that connection with other
specialties. Yeah, it's great. Yeah, we'll have a good team. Yeah.
And what's I suppose some of the things you've referred to, I'm thinking there could be quite a lot of people out there who just live with those things and put up with them. You know, is there a particular treatment you do that's like really successful, really improves people's quality of life that maybe they might not realise?
Well, I think that's the important thing. It's quality of life. You know, a lot of the things that I deal with aren't life or death issues, but they can really significantly affect somebody's quality of life. So, one of the worst things that I see is patients with a nose full of polyps. These polyps are like jelly-like sacs that grow down from the sinuses into the nasal cavity, and they can completely block the nasal cavity. So, if you can imagine what it's like to live with your nose completely blocked. Even if you try to do it for a few minutes, you quickly realise how uncomfortable it is. Yeah. And these are people that can't sleep at night, and they can't smell, can't breathe through their nose. So it really does significantly affect their quality of life. And for people like that, getting the polyps cleared from their nose can give them tremendous relief of their symptoms. So,
Oh, that's amazing. And then do you do cosmetic stuff as well then, if it's to...
Yeah, we do a lot of cosmetic rhinoplasty procedures. So part of my, at the end of my ENT training, I went over to Guildford in Surrey and worked with the guy Julian Rowe-Jones, who has a massive cosmetic practice down there. So I would do a lot of cosmetic rhinoplasty. So typically somebody might present with a hump on their nose that needs reduced, or they're unhappy with the shape of the tip of their nose, and so they would be added to the waiting list for a rhinoplasty or septal rhinoplasty if the nasal septum's deviated on the inside as well. So.
And how big a procedure is that? Because a lot of the discussions we've had with the doctors on these podcasts has been sharing how the treatments have really improved. They've become so much more cutting edge and less invasive.
Well, the procedure that I would do for the nose in a cosmetic area would normally be what's called an open approach. So we make a wee incision in the skin and lift the skin off the nose to get access to the structures underneath. So I don't think the procedure has become less invasive over the years. It still does take an hour and a half, sometimes 2 hours in theatre, depending on what needs done. So it can be a long procedure, but I think it's important that you take the time to get the right result and the right outcome.
And I'm sure that in its way does change people's lives, because it can be quite
very, very much so. Especially you get young girls coming in and they're very unhappy with the shape of their nose. And the way things are these days with social media, their nose is photographed from every angle every day. So when they get an improvement in the shape of their nose, it really, really changes their whole quality of life and their ability to go out and socialise and things like that. So.
Do you? This is a bit of a bonkers question, but does your nose keep growing as you get older?
It does to a small degree. Yes. The cartilage in your nose changes, and you get changes in the stiffness and the strength of the cartilage and the soft tissues of the nose, so it can change in shape slightly as you get older. And you can get conditions where the skin gets thicker and it becomes more obvious on your nose. So, so there are a few ways that it'll change shape slightly as you get older.
And getting back to the kind of more medical issues that you would treat, I mean, have there been new treatments introduced recently, and things that, and potentially things that you can have done in Kingsbridge that maybe would be less available elsewhere?
Yeah, I mean, I think from a research point of view, one of the things that I'm interested in is the processes that are involved in allergic rhinitis and nasal polyps and sinusitis. And what you have there is a very complex pathway where, for example, an allergen like a bit of grass pollen will land on the nasal cavity, and from there you get these antigen presenting cells that take that antigen, the grass pollen, and present it to the immune system. And when the immune system sees that, in some people it overreacts. So you get this cascade of messenger molecules that want the body to react to get rid of this allergen. And it's an overreaction because the allergen isn't that dangerous. So that leads to all sorts of symptoms like blockage in your nose. You get swelling of the lining of the nose, it blocks it up. You get excess mucus production that leads to a runny nose. You get runny eyes, you get sneezing, itching, you get a drip down the back of your throat. So looking at that particular pathway is very important. And there's a similar pathway involved in chronic sinusitis. It's a slightly different type of inflammation, but you've got all these messenger molecules that are triggering the symptoms that the patient experiences. So up until now, we have been using kind of quite blunt tools to manage those symptoms. So we give people antihistamines, and that blocks the histamine part of the allergic rhinitis response. And we give people steroids, which blocks all sorts of inflammation in your body. So we can give them steroid sprays, we can give them steroid tablets, and that can be very effective. But the problem with using a blunt tool like that is that you can also get unintended consequences in other areas of the body. So you can end up getting weight gain with steroids, you can get thinness of the skin, it can affect your overall ability to fight infections. So so if we can target very specific parts of that immune cascade, then we're more likely to be able to treat patients without the side effects. So that's where the research is going. And there are two sides of that. One is a new, a relatively new treatment called sublingual immunotherapy. And that's where we give the patient a small dose of the allergen and they put it onto their tongue and it dissolves onto their tongue. And you take that every day. And what that does is help to modify the body's immune response. So if you're taking a little bit of this grass pollen onto your tongue every day, then eventually your body adapts to it and stops producing that allergic response where you typically get hay fever or allergic rhinitis. So. So sublingual immunotherapy for grass pollen has been around for a few years, and more recently they've just approved a treatment for house dust mite allergy as well. So they're working through the commonest allergens to be able to kind of modify that immune response. And then another side of it is targeting these specific cytokines of these messengers within the immune pathway, and that's done by these drugs that we call biologics. They've already been used in other areas of medicine like arthritis, rheumatoid arthritis, ulcerative colitis, psoriasis can be targeted by these biologics, but we're beginning to realise that we have some drugs now that can affect the inflammatory pathway in the nose and the sinuses. So one of the drugs that was found recently to be very effective was a drug called dupilumab. And in patients with nasal polyps, for example, a lot of them, the polyps can be shrunk right back with these new biologic treatments. Now, there are downsides to them because it's a new treatment. It's cost a lot of money to develop these new drugs, so they're currently very expensive. So they wouldn't be available to everybody on the NHS, and so if somebody wants to pay for them themselves, they're still going to be very expensive. But it does give us some hope for the future for these patients.
It's always good to know there's research happening.
There's a lot going on, and I think over the next 5 or 10 years it'll become much more routine to have access to drugs like that.
And what does cause all these problems? I mean, is it an immune response in most cases?
I mean, that's what it is. It can be a combination of things. So it's the body's immune response, and it develops this kind of inflammation that shouldn't be there. There might be different things that trigger the immune response. You might be genetically susceptible to developing it, and then you get an infection, for example, that takes you on to the next part of that pathway. And still, there's a lot of research going into this to determine exactly what does cause it, but we're moving forward.
And I guess one question that came in was around the whole area of sinusitis and menopause. Is there a connection that you know of? Because there's women who have experienced that worsen at that time in their life.
There's no doubt that hormones can affect the lining of your nose, and changes in your hormone levels can affect can lead to thickening of the lining of the nose, for example, and certainly in patients going through pregnancy, we often see that they're prone to rhinitis symptoms that get swelling and blockage in the nose. And one of the things you'd mentioned earlier was Osler-Weber-Rendu Syndrome, or hereditary hemorrhagic telangiectasia. And
we had a question come in about that as well.
Yeah, it's just that there's a slight connection there, because one of the experimental treatments for that was to use an estrogen cream in the lining of the nose, which would help to thicken up the lining of the nose, and that could make the blood vessels less likely to bleed. It's not a common treatment that we would use, but it has been suggested in the past that it might be helpful. So certainly, your hormones do affect your nose and sinuses to a certain degree. Specifically, I haven't seen too many menopausal women coming in and complaining specifically about sinusitis, so I'm not sure there's a strong connection.
It's a really strong one. And I suppose we referenced Osler-Weber syndrome, and there was a question that came in to the blog on this in terms of just struggling to get support on the NHS. Is there anything that the Kingsbridge could do to help?
I mean, the management of this condition from an ENT point of view is to control the symptoms, and the primary symptom in the ear, nose and throat is nosebleeds. So these are patients who have a genetic condition that leads to the formation of these aberrant blood vessels. And the aberrant blood vessels can form in many different organs in the body. They can form in the brain, they can form in the lungs, they can form in the gastrointestinal tract. But for us, it's common to see them in the nose, and you can see them on the lips and in the lining of the mouth. So, and it's strongly inherited through families. So it's what we call an autosomal dominant disease. So that means that 50% of your family members are likely to get it.
Okay.
You know, so I'm not sure about the management within the NHS. The problem can be that it needs managed by several different specialties.
Okay.
So you might need monitoring of your gastrointestinal tract to see if there are any lesions in there that would need treated. You might need monitoring of your lungs in case there's any lesions in there that need managed.
Okay.
And you might want to identify any lesions in the brain in case there's a risk of a bleed there. You know.
Yeah.
So from an ENT perspective, nosebleeds are the commonest presentation of the condition, and that's why we would see pockets of them throughout Northern Ireland where it runs quite strongly through families.
Family. So would an ENT appointment be a good first?
Well, if there's
spot?
nosebleeds, definitely come for an ENT appointment, and nosebleeds are a good example of something that we can treat there and then, because we can anaesthetize the nose with local anaesthetic spray or pack, and we can cauterize any prominent vessels and do that in the outpatient setting. That can be done within 15 minutes. So, so if it's primarily the nosebleeds, then yes, we can treat that. And there are various other treatments that we'll have if the nosebleeds are too severe that they don't respond to nasal cautery. So, if I suppose it's important to remember, if you do have a heavy persistent nosebleed, you'd be better going to an emergency department. Okay. But certainly if it's more short-lived recurrent nosebleeds, we would be happy to see those in ENT.
Okay. A question in about nasal drip. I have a nasal drip all year round, flares up when I exercise. Help.
Okay.
That's the word.
Yeah, well, we'd probably like to know a bit more about it, any other associated symptoms, but it sounds again like she has what we've been talking about with this kind of inflammatory allergic pathway causing excess mucus production. So I would want to examine the nose to see if there are any signs of allergy there, and allergy testing would be very important in patients like this. We have a new nurse-led allergy service over at the Maypole in Hollywood, and the nurses there can do skin prick testing, take a full history, and if they identify the allergens, they can give you advice about how to manage that. And if it needs medical treatment, they can refer it back to me. So there are a few different ways of approaching it with medical treatment. The first one would probably be a nasal steroid spray. So that's given steroids onto the lining of the nose where they will act to reduce that whole inflammatory process. That reduces the excess mucus production. Typically you have to take a nasal spray regularly every day. I take one myself because I have allergic rhinitis, so it's quite safe to use long term. The amount of steroid in the spray is only minimally absorbed into the body, so you're very unlikely to get side effects from it. So normally see the GP for a steroid spray. An antihistamine can be helpful. Part of the increase in mucus production with your nose with exercise is a natural response from the body whenever you exercise, so you can expect to produce a bit more mucus, but you could reduce it if you're on appropriate treatment.
And we've referred to, I suppose, the allergy and the pollen allergy, and I suppose we're in hay fever season now, and I guess I know lots of people really suffer badly from hay fever. Is there anything that can be done beyond?
Well, again, it's being on a regular steroid spray and an antihistamine.
So it's a similar treatment to this, then?
Yeah, it's a similar thing, and you want to take it throughout the hay fever season. So when somebody who knows that they're going to get hay fever, they want to start their treatment before their symptoms start. So you might start in early April and carry that right through until September. And some people take it all year round. So steroid sprays, antihistamines. Some of the steroid sprays also have an antihistamine in the spray, which can give you a bit of additional benefit. If you know what you're allergic to, you can avoid the allergen to a certain extent. So that's why allergy testing is very important.
So that would be a good first step, I suppose.
Yeah, good first step. You need to be seen, you need to be tested, identify what you're allergic to, and take it from there. Another simple thing that can be done is rinsing your nose with saline and you can get all sorts of saline rinses over the counter in the chemist. And what that does is it just flushes away whatever's irritating your nose. So particularly for people who are working in a dusty environment, if they come in the evening, that dust can accumulate in their nasal pathways and cause irritation and excess mucus production and stuffiness. So if you rinse your nose out every evening with saline, it's just a simple way. It's non-medicinal, so it has very few side effects with it, and that can just help to wash away the allergen.
Yeah, very good. Lots of questions about tonsils and adenoids. So when I was little, everyone had their tonsils out. I felt left out that mine stayed in because they used to get weeks
You're probably
off.
lucky. Yeah.
Well, they used to get weeks off school and they could eat ice cream was all I remembered. But so what is the purpose of tonsils and adenoids, and why do we not maybe take them out like we used to?
Well, we don't take them out in everybody who has a single sore throat because there are potential complications of the surgery, and the main one being a secondary hemorrhage or a bleed after you've had your tonsils out. So there's a risk of bleeding for 2 weeks after the operation, and if you have a bleed, it can be quite distressing. You can end up having to go back into hospital. You can end up having to go back into theatre. You can need a blood transfusion. So that's why we're cautious about who we do the surgery on, and we'll have to make sure that there's a strong enough indication to do the surgery so that the benefits of the surgery outweigh the risks of the surgery. And it's usually done to improve somebody's quality of life. So we get patients presenting with recurrent episodes of tonsillitis, so they might get an episode of tonsillitis every 2 or 3 months, and they're having to take time off school or time off work. And if it's having that sort of an impact on their life, then it's a fairly easy decision to make. You go ahead and do the operation, and they recover at home for a few weeks. We don't recommend that you eat only ice cream during that recovery period. It's important that you eat a varied diet. Chewing regularly helps to keep the throat nice and clean and helps to stop the muscles in your throat from stiffening up and helps with your recovery. So it's not just ice cream.
That's a shame. And what about adenoids then?
Well, adenoids we often do.
And where are they? Sorry,
the adenoids sit at the back of your nose. It's a similar sort of tissue to the tonsils. It's what we call lymphoid tissue, so it's part of the immune system. People sometimes worry about taking out these parts of the immune system that you'd be prone to infections, but your immune system has multiple other areas that can help with fighting infections, so it doesn't have a long-term impact. The main problem with adenoids is that they can block the back of the nose, particularly in children.
Is that because they swell up, or they?
Yeah, they can swell up. They just naturally sometimes they grow bigger than they should grow, and they can swell up whenever you get an infection as well. So if a child gets an upper respiratory tract infection, the adenoids and the tonsils can swell, and that can reduce the space that they have to breathe through. So some children, when they get an infection, they'll be snoring loudly at night. They might have pauses in their breathing. It can be wakening them up regularly during the night. That leads to a child who's tired during the day, can fall behind at school.
Yes.
We would fairly regularly take the tonsils and the adenoids out for symptoms that we would describe as upper airway obstruction.
Yeah.
So, and you'll notice that if your child isn't sleeping well at night, if they're waking up regularly, it might be as well to get them checked out.
Yeah, so that is actually one of the questions. So a little boy age 3, chest in and out while sleeping, snoring, waking up from sleep, noisy breathing, nasal sounding voice, and a concern from the parent that's maybe affecting his hearing. So it sounds like they're being advised to maybe wait till he's a little older, but it maybe sounds like it's worth looking at. It
very much depends on the severity of the symptoms when we intervene, and we can intervene at any stage. Ideally, we like to get a child up to the age of 4, for example, before we would take the tonsils out. But if a child's having trouble breathing every night, that would indicate that we should go ahead and intervene earlier. And intervention can be removing the adenoids. Sometimes it's removing the adenoids and the tonsils at the same time. And in a case like this, the child might actually need grommets or vents in the ears because it sounds like they might have glue ear as well. And the glue ear comes about because the adenoids are enlarged. They block the eustachian tube, which connects the ear to the back of the nose. And when that eustachian tube gets blocked by the enlarged adenoids, they get a fluid buildup in their middle ear behind the eardrums, so they get what's called glue ear. So it's very common in children to have glue ear along with enlarged adenoids and sometimes enlarged tonsils as well.
And I think that was that in addition to the end, that there were some throat infections and ear infections this past year. So, and I guess how invasive is that? Because that sounds scary to me as a parent.
Children bounce back from it very quickly.
Okay.
You know, the procedure might take 20 minutes, half an hour, depending on what needs done and how complicated it is. But it's often done as a day case procedure, so children are in and out in the same day. The one proviso to that is if I have a child who has quite severe obstructive symptoms, so if they have a lot of apneas during the night, and apnea is where they stop breathing, in those circumstances we'd probably keep them in overnight after the surgery to make sure that sometimes when you remove the obstruction, you almost forget to breathe. It's too easy for them to breathe because they've been struggling for so long, so they can drop their oxygen saturation. So in a severe case, we'd probably keep them in overnight, but many of the children that have their tonsils and adenoids out now would be done as a day case. So they're in and out the same day. They go home and recover for 2 weeks at home, and then
Good to go.
The vast majority of them are significantly better after the surgery. So,
and it's always nice to share, I think, stories of. I mean, have you seen that then in kids who've been pretty miserable?
Oh, absolutely, yeah. And I mean, in some children, you can tell as soon as they walk in the door that they need their tonsils and adenoids out, or at least that they need their adenoids out, because I mean they're almost snoring when they're awake. So if you see a child like that, I mean, before the parents give me a history of what's going on, you almost know what's happening, you know. So
you've already got them down for surgery.
Yeah, I've put them on the list, and
And is there an optimum age, or does it really matter?
Well, again, ideally get them up to the age of 4, but it very much depends on the symptoms. It's weighing up the risks of the surgery. If we're taking the tonsils out, there's more risk of having a bleed afterwards. If we're just doing an adenoidectomy, the risks of bleeding are significantly less. So I'll be more inclined to do an adenoidectomy in a younger child. And even if that might mean that they might need their tonsils out at a later date, sometimes we would do the adenoidectomy if they needed vents, put in the vents in their ears to help with their hearing, and maybe bring them back. You know, you obviously want to avoid 2 general anaesthetics if possible, but you also, the priority is to do things safely. So if it's safer to do a sort of a 2-stage procedure, then we might well do that. But we do take tonsils out in younger children as well if we have to.
Okay. So I've had another question about, can asthma cause nose issues like severe catarrh and dry nose, reduced smell? Or would that be typically just...
Well, I mean, we talk about one airway. So the mucosa that lines the airway of the nose and the sinuses is very similar to the mucosa that lines the lungs. So when you get a condition that affects the nose and the sinuses, you often also get lung problems like asthma. And it can go hand in hand with these nasal polyps that we spoke about earlier. It's that same inflammatory pathway. So a lot of patients with asthma do end up with nasal symptoms and chronic sinusitis and vice versa. When I see someone who has chest problems and they also have nose and sinus problems, I would aim to treat their nose and sinus issues. Obviously it'll be a respiratory consultant who's treating the chest, but we do often see an improvement in chest symptoms such as asthma whenever we adequately treat the sinuses. So if you have chronic sinusitis that needs sinus surgery and you remove the polyps and you remove the infection that's in the sinuses and you allow better airflow through the nose, then that often has a beneficial effect on the chest.
On the chest, yeah. Well, that's certainly the case with my own son. He takes antihistamines and it improves his asthma.
It's
just the way it's worked for him. The asthma is actually connected to the...
Yeah, and there are some treatments that are approved for use in patients with nasal polyps and asthma. Singular would be a common one that's used for asthma, and if somebody has nasal polyps, it can be effective there as well. You know, so
very good. Okay, and firstly, red flags. I always like to address. Are there any red flags where people should really? You talked about the the heavy bleeding from the nose. Are there any other kind of red flags?
Well, I suppose a typical one for us would be somebody who comes in with a change of voice. When we talk about red flags, we're thinking about conditions that we want to pick up early that might be caused by a serious condition, typically cancer we're talking about. And if we catch it early in the disease process, it can lead to a significantly better outcome for the patient. So an example that we commonly face in ENT is somebody who presents with hoarseness, change in the voice. And we really want to pick things up early, because if you get a cancer in your larynx or your vocal cords, it can change the quality of your voice at a very early stage. And if you pick that up, then the outcome for the patient can be so much better than if it was left unchecked. So, and I suppose the other important side of this is that most patients that have what we call red flag symptoms don't have cancer. So a lot of what we do is provide reassurance. So we examine the area. When somebody comes to see us in the clinic in the Kingsbridge, we can pass a flexible scope down through the nose, and that lets us visualize the vocal cords down here. And in most cases we're saying, look, there's nothing serious here. You might have a bit of inflammation or a bit of mucus in your throat, or you might have signs that you have a bit of reflux coming up from your stomach and causing a change in your voice. But if there's something sinister there, we can see what's there, get the patient in for a biopsy, and then start them on the pathway of treatment. And as I say, the surgery for throat cancer can be very destructive, but if you catch it early on, it's minimal, and sometimes invasive surgery isn't even required.
Yeah, but that would be the main kind of...
Yeah, I mean, there are lots of other red flag symptoms in ENT. I mean, if somebody has difficulty swallowing, if they notice a lump in their throat, any lumps in the neck need to be looked at fairly quickly. And again, a lot of lumps in the neck are totally benign, but we need to look at them and investigate them. Yeah. You want to be looking in your mouth for any red plaques or white plaques, or any ulcers that aren't improving, or any new lumps in the lining of your mouth or your throat. They should be seen too. From my kind of rhinology subspecialty, I'm thinking about sinus issues. One of the things in ENT, we always think if a symptom is unilateral, so if it's just affecting one side, that there's more risk associated with that. So if somebody comes with unilateral facial pain or unilateral numbness or a gradual onset of unilateral nasal blockage, then we might be concerned that there could be something growing in their sinuses and it would need investigated. So, and also unilateral ear pain is another one that sometimes ear pain can be referred from a tumour in the throat. So if somebody's getting pain just in one ear, we would certainly want to see them sooner rather than later.
Okay, well, that's good to know. Good to know. Is, I suppose, lifestyle, and I guess I think, because we've been talking about it being quite immune driven, so I'm guessing lifestyle changes will certainly help.
Well, the various things in ENT that can be affected by your lifestyle. I think the important message for me to get across would be to reduce the serious risk factors. So smoking is by far the biggest cause of head and neck cancer. So you want to reduce or preferably stop your smoking altogether. Yeah. Excess alcohol consumption is also a risk factor. From the less serious things that we could change with lifestyle factors. Again, we talked about rinsing your nose out if you're working in a dusty environment on a building site, that sort of thing. That can help to keep your nose in good shape. Weight control is another one that's very important, because in ENT we would see a lot of patients who are overweight, and that leads to snoring, sleep apnea, and just like it has an effect on the children, that can make them fall behind at school. It can give people difficulty keeping awake throughout the day at work, and getting, maybe being less productive than they should be at work and things like that, So, and it can also ultimately, if you're snoring to the extent where you're into sleep apnea, where you're stopping breathing at night, that can also have an impact on your overall health, put up your blood pressure, and make you have more risk of strokes and heart attacks and things like that. So you do need to manage your weight to keep your airway open at night.
Makes sense. And I have to mention snoring, seeing as you said it already. So I'm one of many women who puts up with that on a nightly basis. Is there anything you can do to stop your husband snoring?
Well, first of all, most important thing is to control any excess weight. So any excess weight around the neck of the throat reduces the space of the airway at night, and that leads to fluttering of the soft tissues in your throat, which leads to snoring. So weight loss would be the first thing. Treatment-wise, the first thing that I would always say to patients is to consider what's called a mandibular advancement splint. And that's where they wear a device like a bite guard, and it's designed to hold the jaw forward at night, and it brings the jaw forward just by a few millimeters, and that brings the tongue away from the back of the throat, and that reduces the snoring that way.
Okay.
From a nasal aspect, we would always want somebody to have a clear nose, because if your nose is blocked, again, you're more likely to mouth breathe and snore at night. So if there was, for example, a deviated nasal septum that was causing nasal blockage, then we would want to correct that. If there are nasal polyps or rhinitis, we would want to treat that to help. It doesn't always take away the snoring, but it certainly is one of the steps in helping snoring.
Okay, so there are a few options.
There's a few options, yes.
Yeah. No, that's great. Thank you so much. I found that really interesting, and I think the breadth of what you do, I wasn't really fully aware of the real breadth of treatments. Thank you so much for your time today, Dr. Turlough.
Thank you very much.